connecting, but come on in, have a seat, get ready for this next great presentation. I hope you're here to join us for why the hate for Naltrexone. Did I say that right, Jeff? Please, or Ben, please correct me.
Naltrexone.
Naltrexone, thank you.
Nobody can pronounce it right. It's like unpronounceable.
Well, good. I'm glad I can fit in with the everybody crowd there and not be too off that outlier. As you guys are getting settled, I'd like to start off with just a couple of reminders. My name is Crystal Dalmaso. I am the moderator for this session. So if you have any tech issues, please reach out to me. This session is being recorded and will be available on the conference platform 1 hour after our session ends today. We are asking that you keep yourself muted. So watch that mute button. Unless we ask, unless Ben asks for you to unmute yourself, we ask that you keep yourself muted because we are recording our session today. Make sure that you join our sessions live today because we are doing a prize drawing for, from the attendance with each session. So the conference is also offering free continuing education credits. So make sure that you visit the continuing education page, and also make sure that you connect with us and join the chat in the conference platform. You can use it there. You can also use the chat here on this page as well. So what I'd like to do now is introduce Mr. Ben Westhoff. He is an award-winning investigative reporter. He's based in St. Louis. His book, Fentanyl Inc., How Rogue Chemists Created the Deadliest Wave of the Opioid Epidemic, is a bombshell first book about the fentanyl epidemic, and he has advised officials at top levels of government about the crisis, including the U.S. Senate, the House of Representatives, the White House Office of National Drug Control Policy, the DEA, and the U.S. State Department. He's written for the Atlantic, the Wall Street Journal, the Rolling Stones, and the Guardian. Not to fear, if you want to read another book, he has another one coming out in May. His next book, Little Brother, is about the murder of his mentee in the Big Brothers and Big Sisters program. So you can be looking for that in May. Without any more time of yours taken up, I'd like to turn it over to Mr. Ben Westhoff.
Thank you very much, Crystal. I really appreciate it. I just will say you can feel free to, throughout the presentation, to ask comments in the chat box. Some of the stuff is a little bit complicated, so do not hesitate to ask questions. I will not be offended at all. It will not mess up my flow. And I'll also take questions at the end. So I am going to get my presentation going here. All right. So on the left here, this is my friend Mike. I met Mike because he was the best friend of a guy named Jarrell Cleveland, who was my mentee in the Big Brothers, Big Sisters program for 11 years. Jarrell was murdered in 2016, and Mike and I took his death pretty hard. In fact, Mike, pictured here, began descending into a bad situation with heroin. I tried to help him. I connected him to a clinic that was dispensing the treatment drug buprenorphine. Unfortunately, though I wouldn't find this out till later, he sold it to buy heroin. And the same thing happened when he got methadone. He just sold it to buy more heroin. In early 2019, he was convicted of robbery, and he did about 2.5 years in prison. And so when Mike was set to get out in August, a few months ago, I knew he was in a really serious situation because prisoners who are just released have a very high rate of relapse, and they often die immediately from a drug overdose when they get out. The way I saw it, our mutual friend Jarrell had already died on my watch, and I wasn't going to let the same thing happen to Mike. I firmly believed that what he needed was medication-assisted treatment, which is a combination of treatment drugs and counseling. But the question was, which treatment drugs? Now, I considered myself to be fairly well informed about medication-assisted treatment, or MAT. In fact, in 2019, I published a book about the fentanyl epidemic called Fentanyl Inc. It talks a lot about addiction to fentanyl, heroin, opioid pills. And in the process of writing it, I interviewed about 150 people, everyone from users to government officials to law enforcement officers. I traveled all over the world, really to learn about different ways that doctors and public health experts are treating drug abuse and saving lives. This is from a festival I went to in Spain. And some of this Spanish I can read and some of it I can't. My book focused in part on the dance music community, where a lot of these new drugs have emerged, and where there are a lot of bright young folks who are focused on how to fight overdoses, how to stop misinformation, and how to prevent unsafe drug use. This group is largely focused on the philosophy of harm reduction, which was one of the main themes of my book. Harm reduction is basically a philosophy that says we can't stop people from using drugs. People are always going to use drugs. So we have to make sure to educate them, help them use more safely. And I spoke to a lot of different harm reduction experts about medication-assisted treatment. So there are 3 medications approved for MAT, but they have different modes of action. Methadone is the most famous. It's an addictive opioid in itself, as is buprenorphine. These are both known as agonists. Meanwhile, another medication-assisted treatment medication called Naltrexone is what's known as an antagonist because it blocks the receptors. So taking opioids has no effect on the user. So, you could theoretically take $100 worth of heroin and not get high at all. The thing is, though, that I didn't really learn much about naltrexone during my reporting for Fentanyl Inc. That's because everyone I talked to was so focused on methadone and buprenorphine. So then in 2019, I went on my book tour. It was the lights, the glamour, the action. The crowds I spoke to were usually pretty receptive. But at an event in St. Louis, this guy named Percy Menzies came up to me afterwards and told me that I had it all wrong. So this is Percy. He's the founder of the Assisted Recovery Centers of America, based in St. Louis. He's a very blunt guy. He basically told me that when it came to medication-assisted treatment, I was full of it. I said, well, thank you, thanks for your input, and then tried to find a polite way out of the conversation. After that, he started sending me emails, which I, more or less ignored. But, but after some time, though, what he said started coming back to me. I started thinking more about it, and I really couldn't shut it out. So I just decided it was finally time to do my actual homework on naltrexone. And, it's a very interesting drug. I had no idea that it was basically the same chemical as naloxone, AKA Narcan, which is the miracle opioid reversal drug. And, Narcan is lauded in the harm reduction community, and with good reason. A lot of people think that if we provide more Narcan, to first responders, people who know people who are potential opioid overdose victims, that we could really make a serious dent in this crisis. But the difference is that while Narcan is given after an OD, naltrexone is given preventatively. So you have to be totally detoxed to take naltrexone. You can take naltrexone while you still have opioids in your system, but it will cause a very, very unpleasant reaction. But you know, if you're totally detoxed, you take naltrexone, specifically a shot branded as the drug Vivitrol, then you're safe from opioids for about 25 days. The opioids, if they're taken, will just bounce right off the opioid receptors. Naltrexone's advocates talked about it being particularly beneficial for people with opioid use disorder just getting out of prison, as these people tend to be already detoxed. It sounded like it could be a good fit for my friend Mike, who is getting out soon. But as I kept researching naltrexone, I was shocked to find out about how infrequently it was written about in the mainstream press. There were a number of studies and academic papers about it, but very little was put into layman's terms. The majority of the articles that I read in mainstream publications about medication-assisted treatment barely mentioned naltrexone at all. The focus was almost entirely on methadone and buprenorphine. So I circled back with some of the harm reduction people I'd spoken to for Fentanyl Inc. Most of them dismissed naltrexone out of hand. You know, they made some good points. They said that one big disadvantage of naltrexone is that it's difficult to get people started on it in the first place because you need to be totally detoxed. And naltrexone also doesn't relieve cravings. Some also said that naltrexone is dangerous because when people drop off of it, as people inevitably do off of every type of treatment, their tolerance goes back to zero, putting them potentially at more susceptible to overdose. I would add, though, that in this age of fentanyl, you know, which is 50 times stronger than heroin, it's important to remember that, you know, even people with high tolerances to drugs like heroin are overdosing and dying the very first time they use fentanyl. So, you know, so other people I talked to said that naltrexone blocks people from experiencing pleasure. And I heard this a lot, actually, though I later found out that it was not true. One person leveled with me and said that many harm reduction advocates simply blanch at the word abstinence. Like I said, naltrexone blocks opioids, so it's seen as the abstinence option, even though it's, you know, it is a drug itself. Disdain for the word abstinence harkens back to, you know, Christian right, misguided sex ed policies and just say no and all these other cultural touchstones. I'm certainly no fan of just say no. I think it was a failed campaign. But I was shocked to learn that the harm reduction people I talked to didn't see naltrexone as a critical part of this fight. You know, in the battle against opioids, which gets worse every year, shouldn't we use all the available tools to fight it? So I began looking further into the data. You know, the first question I wanted to answer was, which do the academic studies say works better? Antagonists like methadone, agonists like methadone or buprenorphine, or antagonists like naltrexone? It turns out this is a pretty difficult question to answer because the drugs are very hard to compare. You know, they're on two complete opposite ends of the spectrum. One is, you know, methadone and buprenorphine are addictive opioids in themselves, whereas naltrexone, you have to be completely off opioids even to take it. The short answer is that most studies say that they're approximately equally effective when you can get people to take them. So the last qualifier is key because, as I mentioned, it's more difficult to get people to take naltrexone because they have to be detoxed. And also because, well, it doesn't give you that comfortable, stress relieving feeling that you get from opioids. Also important, though, is the quality of life people have when they're on these different medication-assisted treatments. A new study shows that Vivitrol, which remember is the naltrexone shot, is associated with higher life satisfaction compared with buprenorphine. And I have to say, this doesn't really surprise me, as I guessed, as a lot of people might intuitively guess, that a life where you're not dependent on opioids is preferable to one where you're still addicted. So yeah, there's been plenty of criticism against the company that makes Vivitrol, and the company is called Alkermes. It's been criticized for deceptive marketing, as well as for receiving its FDA approval based on a controversial Russian study, which many believe was picked for its location because agonists like methadone and buprenorphine aren't allowed in Russia. The critics say that doing a placebo study, as was done in this Alkermes study, was unethical since the agonists, methadone and buprenorphine, had already been established as the standard of care. Critics of this company, Alkermes, also don't like how the company lobbies courts and judges, who, of course, are not doctors, and yet they have often pressured defendants and people getting released from prison to take Vivitrol and Vivitrol only. And Daniel Warren says they have also paid legislators to include Vivitrol by name in state laws related to OUD treatment as a preferred medication. Yes, there is certainly a lot to dislike about this company. Okay, but when it comes to the opioid treatment industry, there's plenty of criticism to go around. You can start with the fact that methadone was invented in Nazi Germany. According to the BBC, it was tested on prisoners in concentration camps. So fast forward to today, guess which company owns more methadone clinics than any other? That's right, Bain Capital, the private equity company where Mitt Romney once worked. In 2006, Bain paid $723 million to buy the owner of a chain of methadone clinics called CRC Health Corporation. It was pretty savvy timing considering the opioid epidemic was just getting revved up. Bain knows their business. Overall, for-profit companies now own the majority of methadone clinics in the United States. So a cynical person might ask, what incentive do they have to get anyone off methadone? Rob Bragg is the Assistant Commissioner of Tennessee's Department of Mental Health and Substance Abuse Services. And he told for an article, he talked to an organization called the Physicians for a National Health Program. So he said, with a nonprofit, the incentive is to get people to treatment and wean them off. When you have a for-profit and a cash-only business, there is no incentive to detox them. In fact, there's an incentive not to detox them because of the continual cash flow. So, of course, the medical industry generally has become highly corporate and profit-driven. And this is certainly true of the recovery industry as well. In 2016, according to SAMHSA, 62% of methadone clients receive treatment at for-profit opioid treatment programs, or OTPs, and 32% receive treatment at nonprofit OTPs. For buprenorphine, it was 67% of people received treatment at for-profit OTPs and 25% at nonprofit OTPs. For Vivitrol / Naltrexone, it was 55% of people received treatment at nonprofit OTPs, and 28% received it at for-profit OTPs. You know, people who I talk to, people extolling the benefits of methadone, you know, believe that there's very little diversion. That is, people selling or trading their meds. But diversion is difficult to measure. My friend Mike told me about his own experiences with diversion, which I talked about earlier. And a different St. Louis area methadone user told me that diversion is rampant, that people are doing it right in the parking lot after receiving their doses. The biggest problem, you know, with diversion really right now is that many users are trading their treatment drugs, their methadone, their buprenorphine, for fentanyl or heroin, which very often has fentanyl in it. And this can kill people immediately. Naltrexone obviously doesn't really have a street value, you know, because like I said, it's not an opioid that gives you a sense of any euphoria at all. Another issue is that methadone is a very dangerous drug in itself that kills thousands of people annually. So now most of the methadone deaths shown here in the 2000s weren't because it was being prescribed for addiction, okay? Instead, methadone was frequently prescribed as a low-cost painkiller available as a generic. But still, as you can see, the results were disastrous. For the better part of the decade, as you can see, you know, starting around 2002, methadone was killing more people than heroin. And then that went all the way through past 2010. You know, and that's not the only problem. Many opioid use disorder patients say that methadone is more addictive than heroin. And further, even when it is prescribed for addiction, methadone and buprenorphine have been responsible for thousands of deaths in their own rights. So the buprenorphine, you know, the buprenorphine industry has been corrupt as well. In 2019, the company that makes Suboxone was forced to pay $1.4 billion, which is the largest opioid settlement in US history at the time, over illegal marketing and for claiming that its strips were less addictive and safer than other drugs containing buprenorphine. They also had a web and a phone program as a resource for opioid addicted patients, which was allegedly actually just a method of connecting those patients to doctors that were already prescribing Suboxone and other opioids. Suboxone is the brand of buprenorphine. According to the Department of Justice, these doctors were prescribing Suboxone and other opioids to more patients than allowed by federal law at high doses and in a careless and clinically unwarranted manner. Nonetheless, as you can see, buprenorphine and methadone dominate the market. So you probably know this, but methadone can only be dispensed from special clinics. As of 2018, there were over 1,600 methadone clinics in the US. And as far as I can tell, very few of them, if any, you know, I don't know, but it seems that very few of them offer naltrexone. When it comes to opioid treatment programs, as of 2015, 58% of them offered buprenorphine, while only 23% offer naltrexone. One advantage of naltrexone is that any doctor can prescribe it. With buprenorphine, the doctor has to undergo special training, and she or he is limited to how many people they can prescribe it to. But the fact that so few opioid treatment programs even offer naltrexone seems strange to me. You know, why don't all OTPs offer buprenorphine and naltrexone? Why don't methadone clinics offer naltrexone? I know there's a lot of red tape out there, and hopefully things are starting to change. but it also seems that there are a lot of hearts and minds that need to be won over. So just to clarify, you know, I'm not trying to say that antagonists are better, that agonists are better. I'm not trying to say methadone and buprenorphine are better. I'm not trying to say naltrexone is better. I think they're all very important kits in the recovery tool belt. You know, methadone is important, buprenorphine is important, and naltrexone, I think, needs to be a larger part of the conversation. Okay, Dana says OTPs and methadone clinics are one and the same. I thought OTPs were more inclusive. So we will check. We will have to check on that. All right. So, okay, so just a little bit more about that. You know, Percy Menzies likes to say that the discovery of naltrexone should have been a penicillin moment, you know, and we already know of many other benefits from it. In addition to opioid abuse, naltrexone is also effective for curbing alcoholism, and the FDA has approved it for that purpose. And low-dose naltrexone shows great promise in treating meth addiction, anorexia, infertility, and you know, there's a lot more. I even had a friend email me out of the blue who said that absolutely nothing helped her Crohn's disease until low-dose naltrexone put it into almost complete remission. So to me, it sounds like, you know, a drug that deserves further study. So let's see, you got a couple of comments here. Yeah, so Anthony Strickland responded, that is an OBAT, office-based addiction treatment, which any physician can be certified to do integrated into their practice. Exactly. So I hope that clarifies. Methadone, the only place that can distribute methadone is a methadone clinic. So ultimately, I think in some ways, the debate comes down to one question. Do you believe that opioid use disorder patients can quit bad drugs like heroin and fentanyl, or do you not believe that they can? To me, I think that's a very central question here. So doctors Vincent Dole and Marie Niswander popularized methadone. They're pictured here. So they believed that heroin addiction was what they called metabolic disease. Okay, so, you know, they're very interesting people. Marie Niswander actually had a clinic in which she, in Harlem, in which she saw people right off the street with heroin problems, including, you know, jazz musicians, and she worked very closely with her patients. And then eventually she ended up working at the Farm, which was a federal drug prison in Lexington, Kentucky, where Vincent Dole ended up being too. And so this was a very unique program. It was kind of seen as a sort of humanitarian way to deal with drug offenders rather than sort of locking them up in some maximum security prison and throwing away the key. They were sent to the Farm, and it was called that because they literally grew corn. They had, you know, animal husbandry, they had basket weaving classes, and, you know, the inmates also served as kind of human guinea pigs for new drugs being tested. But so basically Dole and Niswander started working together, and they popularized methadone. They eventually got married, but they basically had this theory of heroin as a metabolic disease. And so, in the words of the journalist Edward J. Epstein, this theory holds that heroin abuse under certain conditions induces a permanent change in the nervous system that can be compensated for only by the ingestion of heroin or other opiates. Without opiates, people with this metabolic disorder are physiologically unable to function and are medically abnormal. Since the metabolic change produced by heroin abuse cannot be reversed, the only possible medical treatment is to maintain the patient on a less harmful opiate than heroin for the duration of their life. And so that's where methadone comes in. So what's really interesting is that at the same time, at the farm in Lexington, Kentucky, this would have been the 50s and 60s, there was another doctor working there named Abraham Wickler. And he, as opposed to the metabolic theory of Dole and Niswander, he advocated for a Pavlovian theory of addiction. So in the words of addiction specialist Richard Resnick, he described it this way: just as Pavlov's dogs salivate when the bell is rung, once it has been paired with the smell of meat, in the former addicted user, external and internal cues that previously were associated with heroin serve as bells that make them crave the drug. To extinguish the conditioned response of salivation in Pavlov's dogs, the bells must continue to ring but never again be associated with meat. And so one example that he kept hearing about again and again was that these opioid use disorder patients from New York would come out to Kentucky to the farm, and they would be opiate free for years. They would be doing great. But then when it was finally time for them to return home, they might be on a bus crossing the George Washington Bridge back into New York City. And almost to a one, he said, right when they started crossing that bridge, they felt this craving come over them, this sudden desire to take heroin again, something that they had seemingly successfully quit and had no interest in, for years now. And this is exactly the example he was using, the sort of the cues, the external and internal cues that make them want to use heroin. And that's what he observed again and again. So that's where naltrexone comes in, because the idea is that if you take naltrexone and you find yourself in the environments where opioids are present, the places where you used to get high, you stop associating these environments with getting high, because the naltrexone blocks the euphoria from the opioids. So it was directly out of Abraham Wickler's research that naltrexone was developed. So now again, I don't know which theory is correct. I don't know if it's the Dole and Niswander theory in favor of methadone or the Abraham Wickler theory in favor of naltrexone. And again, I'm not here to tell you which is better, the agonist or the antagonist. But like I said, I think both are sorely needed during this most dire drug epidemic in American history. All I can say is that I consider myself a generally optimistic person. I've heard so many stories about people who are able to quit opioids. I've heard these stories. I'm sure you've heard these stories too. And I've also heard about plenty of stories of people who can't. And for this latter group, I would certainly say that agonists are a tremendous solution. If someone can't quit, methadone maintenance or taking buprenorphine has, I know for a fact, helped lots and lots of people return to have their lives back and operate completely functionally and normally. And I can't say that enough. But for the subset of people who want to go totally drug free, who don't want to have to take another addicting opioid, these people should be told about naltrexone and have the opportunity to take it. But like I said, the problem is that naltrexone is just not out there in the consciousness. It's not offered in as many places. It's barely mentioned in the news at all. The harm reduction community barely acknowledges its existence. So I think that needs to change. So as for my friend Mike, he is doing great. He's been out of prison for almost 3 months now. He's taken the Vivitrol shot 4 times. So, like I said, it's been a few months. Hopefully he's made it through the roughest stretch. He's got a new job. He's got a girlfriend. He's got, a new lease on life. So it's too early to say. Who knows what the future holds? But I'm very, very excited for him. And that is about it. Thanks everybody for listening to the presentation. I know this is kind of a fairly controversial topic, so I've tried to, really take it on with care. I see there's already been some comments that I haven't gotten to, so I'm going to. It looks like we've got about 9 minutes. So everybody, or no, maybe we have more time than that. We go to 12:15. Okay, so we will have time for some more questions. So you can start. I'm going to stop sharing my screen. So you can start asking me any questions that you would want. So Tamara Johnston said, how does it help with meth addiction and alcohol exactly? So I cannot answer those questions to a very satisfactory degree. With meth, it's not FDA approved for meth addiction, and I'm not sure the mode of action or how it supposedly can help with that. As for alcohol, though, it is FDA approved. It's actually been approved for alcohol for longer than it has for opioids. And people have tremendous success. Again, I don't know how it works. It has something to do with the pleasure, the endorphins that people get from using alcohol. And I think I'm already getting this terminology wrong, but people have found a ton of success. I think it's not always advocated for or preferred by groups like AA, which want people not to be taking any drugs. And even though naltrexone is a blocker, it is still a drug. And so I know it's controversial in some of those circuits. So all right, let's see, some very long comments from Anthony Strickland. This is a lot. This is pretty long, Anthony. I would invite you, if you want to turn your mic on and make your point. I'm happy to hear it. But this is what you posted is pretty long.
Yeah, apologies. Sorry, I was just trying to put a reference with resource from ASAM on the mechanism of action for naltrexone with alcohol use disorder.
Thank you. That is very helpful. And it looks like you've got a lot of sort of very thoughtful comments. So do you want to maybe just sum up in general how naltrexone works for alcoholism?
So again, we know that it affects more than just the mu-opioid receptors. And so there's some various systems in the brain that are acting in the reward response pathway, that it decreases those cravings substantially in alcohol use disorder, even though it's not directly blocking any of the receptors. And that's one of the way that it works. And it's particularly effective. I've found long-acting naltrexone to be most effective in those individuals with severe alcohol use disorder that didn't respond to other treatments, even sometimes for decades.
Wow, that's great. So what's your background? Have you worked with patients like this?
Yes, so I'm a family medicine doctor and an addiction medicine specialist. I'm the agency medical director for DECA.
Okay. Well, very cool. And sort of anecdotally, because I know the course of action is not exactly the same. Like with the mu receptors for opioids, when it blocks, when naltrexone blocks opioids, the bad opioids, people like literally don't experience anything. But I've heard when taking naltrexone and drinking alcohol that some people can get a little bit drunk or something like that. I'm not exactly sure how that works.
Yeah, so the mechanism of action for alcohol and opiates is quite different. So you can drink alcohol when you take naltrexone. It doesn't prevent you from getting drunk or anything like that. It just decreases cravings. It doesn't work like in an anti-abuse type way. However, for opiates, it does directly block the mu-opioid receptor. And so it can take very, very high doses of an opioid to override that effect. And so it essentially blocks the ability for an opioid to cause any kind of high in those individuals, again, unless you push a very high amount of opioid to succumb it or overcome it.
That's great. Well, thank you. Thank you very much for that.
Mm-hmm.
Someone raised his hand, Daniel Warren. Thank you.
Hey, thanks, Ben. I want to start off by saying I appreciate, I saw you at the conference a couple of years ago. Really enjoyed what you had to say about fentanyl, kind of bringing it into people's awareness in Kansas, because it's like we've been watching this wave come in from far in on the shore for a long time, and it's only finally just kind of hit, and people were still really not ready for it when it came. Treatment centers in Kansas still aren't testing for fentanyl. We're not finding ways to get people onto any kind of medication-assisted treatment the way that we need to. People are still surprised. So coroners don't test for it. I mean, it's just like it's still a disaster, and the numbers are bad, but they're going to get worse. And I just don't think people are ready. I do want to say a few things. So I'm the medical director at an OTP. I worked at KU School of Medicine and see patients at a federally qualified health center to do buprenorphine. I'm addiction fellowship trained, and I use naltrexone in my fellowship training. I would say the primary reason why OTPs don't use it and why it's not used in general is because the washout period is so difficult. We're talking about a population of people where if you ask most of them how long is the longest they've gone without using opioids when they are treatment seeking, the treatment seeking population will generally say 3-4 days at most. And now with fentanyl being kind of the predominant opioid that's being used in our community, we really need a 10 to 14 day washout period for people to effectively get transitioned.
Oh, really? I hadn't heard that it was that long.
Yeah. So when I tell people that, and I do informed consent with all my patients, and I let them know about the 3 different medicines that are involved in opioid use disorder treatment, I tell them, hey, you have to be off your medications for at least 7, 10, 14 days. And they say, listen, if I could be off for 7, 10, or 14 days, I wouldn't be sitting here right now. It is phenomenally difficult to get people started on it. And the evidence is not there in terms of mortality benefit either. And that's what's also troubling is we talk about methadone causing some deaths, and it's been right around 3,000 deaths per year attributed to methadone overdoses nationally for the last 20 years. And that's been a nice thing that it's been so low, considering 400 or 500,000 people are currently on methadone treatment. And we know that based on some of the epidemiological research that's been done, we have to treat about 40 people on methadone for 1 year in order to save one person's life. So that means on average, we're saving probably 10,000 lives a year from methadone treatment. Buprenorphine, the number needed to treat for life-saving benefit is not quite as good. The problem is naltrexone has no mortality data except for situations when people are coming out of incarceration. And there is a mortality benefit there, absolutely. And it's easy to start because people are generally on an abstinence only program when they're incarcerated. Now, certainly people can sneak drugs into jail and prison and other settings. That's not like unheard of. But for a person who is really super motivated and coming out of incarceration, especially, is a good time for this. Extended release naltrexone definitely is a life-saving medication. I would say for almost everybody else who is treatment seeking, the barriers to initiation are so high that that the time it takes to consent people into doing other treatment, it's almost not worth, because it is so unlikely that people will be interested in it. And so where I did my fellowship training in Portland, Oregon, we offered naltrexone at the OTP. We had about 1,000 people at the OTP. Most of them were on methadone. Some of them were on buprenorphine. And at any given time, we had no more than 1% on naltrexone. And that's despite doing informed consent for all those people. And that's despite having everybody in that state on Medicaid and able to be, like, for us to get reimbursed for the naltrexone, which is also like a huge barrier because the cost of it, $1,000 to $1,500 a month just for the medication cost in places like Kansas where we don't have Medicaid expansion becomes just a huge barrier for people as well. There are other things. I mean, I'm not antagonistic towards antagonist treatment. Yeah, thank you for that. It is such a high bar to set for most people, for professionals, pilots, doctors, et cetera, who are engaged in substance use treatment, who have to be on an antagonist. They are usually highly motivated. The rest of the population out there is going to say, listen, if I don't have access to medically managed withdrawal, and even if I do, it's so hard to go through that 7 to 14 day washout period. I mean, that by itself.
Well, yeah. Well, I mean, this is all really helpful, and I appreciate it. I mean, a lot of things I want to say. One is that, you know, it does say a lot that, you know, for like, if you're an airplane pilot, you can be on naltrexone, but you can't be on, you know, an agonist. And I think that says a lot right there. I've also, the 14-day window is much longer than I've heard for anyone else. I know, you know, at ARCA, you know, Percy Menzies was telling me that really it's like, it's a 7-day window for most of the people he sees, and even less. But you know, I'm sure that in the age of fentanyl that can, you know, be worse. Another thing is that, like, the cost has been, I know, traditionally prohibitive, but even in Missouri, you know, where I live, and we just got the Medicaid expansion, but there, you know, it's covered, you know, in St. Louis, everyone can receive it. Like Mike received it for free, and I can't speak to Kansas, but I do know that the way things are trending is down, and things are, there's a lot of federal money like really pouring in right now, and it's easier probably than ever for a lot of people to get this medication. But you know, your larger point that it is difficult to get people inducted or to get people on it is really true, and it can be very difficult to do this sort of drying out period. But you know, my main point is just that there are highly motivated people out there, and some people are motivated by the possibility that there is this, you know, what some have called like a miracle drug possibility for them. You know, I mean, if you're there's so many people who I've talked to who really do want to quit forever, and they don't, you know, they are highly motivated, and these aren't, you know, just white collar people who are doing it for their jobs. But you make a lot of really good points, and I really want to thank you. Let's see. I had another comment from Anthony Strickland. It's interesting that you found so much resistance to long-acting naltrexone. I found much more resistance from community partners to buprenorphine, especially in law enforcement. So I think, you know, part of it might be sort of like the red state, blue state divide. And I, even though I live in Missouri, which is certainly bright red, a lot of the harm reduction people I've talked to, and I come from a background in media, and it's very sort of like, I don't know how it came to be this way, but naltrexone has kind of come down to be seen as like the red state America preferred drug, and buprenorphine, methadone more the blue state. And I think that, you know, might be tied up in this idea of naltrexone being the abstinence drug. But I've certainly heard what you're saying about law enforcement, that there has been a bias in certain quarters against the agonists, and I absolutely think that's a shame too. I think for a lot of law enforcement people, you know, it might be this sort of idea that naltrexone is not a drug. It's not a drug that could potentially get you high. I mean, the reality is that certain people who are taking methadone and even buprenorphine sometimes do get high, you know, and maybe it's their dosage is too high and whatnot, but it's seen as a drug. I mean, these are seen as street drugs. And so for a lot of police, it might be kind of hard to get their heads around the idea that we're, you know, someone who's been in treatment or someone who's broken the law, that they should be given more drugs. And again, I think this is not sensible. And I think that absolutely the agonists and the antagonists should be available. Let's see. Daniel Warren said, also worth noting, it's no longer necessary as of April for prescribers to do any training prior to buprenorphine prescribing. All that's required is submitting a notification of intent to SAMHSA. That is very, very much worth noting. And I think that is great. I mean, I think, I don't know why in the first place there was this sort of added level of training for buprenorphine prescribing for there to be a limit on the number of patients. None of that made any sense to me to begin with. And Anthony Strickland said also it's very important to differentiate the safety profiles between partial agonists like buprenorphine and full agonists like methadone. Yeah, Anthony, if you want to talk on that, I agree it's important. If you want to talk about that, you feel free to unmute yourself.
Sure, and this is something that I don't know. There's probably quite a few folks who are familiar with that on this in this meeting, but because buprenorphine is a partial agonist, it both binds and blocks the receptor. So it's kind of a middle ground between full agonists like methadone and the antagonists like naltrexone. And so it's actually very safe and very difficult to overdose on by itself. Now, obviously in combination with benzodiazepines or in the attempts to overcome that blockade, it can be dangerous, but I find that's exceedingly unlikely. In my years of doing this, I've never had a patient have a life-threatening event with naltrexone alone. Again, that's my experience, but statistically that holds true as well. Now, methadone has a place, and there's and the efficacy with methadone. Dr. Warren is a rock star in Kansas, and most of us are very happy to draw on his experience. And I also practice in Missouri, and I see a lot of that as well. And that being able to get people on naltrexone, if you can get them on it, it's fantastic. I take care of a lot of folks right out of like sometimes a 4-week treatment center where they've been abstinent, and that's a great opportunity. But when you're meeting people on the street who've been using in the last 24 to 48 hours, that 7 to 10 window can feel like a lifetime. It's very difficult. So I completely agree with you, Dr. Warren, on that. But if there are questions about the mechanism of action with buprenorphine or full agonists and partial agonists, if somebody messaged me, I'm happy to tell them some more information when it's not using up your time.
Oh, well, thank you. Yeah, I appreciate that. And I'm curious, are you in a kind of more rural or more kind of urban area?
So my primary care practice and where my office based is addiction treatment and primary care practices, and it's Excelsior Springs, Missouri. So it's right on the edge of Kansas City, kind of in Clay County, right on the edge of Ray County.
Okay. So I'm not too familiar with that area. Is that more kind of rural?
It's
a kind of more suburban. What'd you say?
It's very close to Kansas City, but a very rural population.
Yeah. Okay. Yeah, and that's, I think the challenge for a rural population is like a whole different set of worms, and for a whole different can of worms than for an urban population. I got to imagine that it's very difficult to even find to serve this community, which is spread over such a large geographic area. So, all right, well, let's see. I'm kind of worried that I missed some questions here. So if I did, feel free to pop it back down to write it again in the chat. Let's see here. Yeah, the more talk about alchemies and these different companies marketing these drugs. Yeah, it's the more you look into these companies, the more kind of sleaziness you're going to find. Okay, great. Okay, great. And thank you, Dr. Warren, for the invitation to your clinic. That's great. So if there's any, if we don't have any more questions, thank you to everyone for listening and for being a part. And I'm also happy to talk with anyone else. I'll leave my email in the chat, and by all means, do not hesitate to reach out. And thank you again to everybody.
Thanks, Ben. Remember to grab his email off the chat. I'm going to put post it again in the chat here for everybody to see. So grab his email off the chat. That way, if you have more questions, you can email him directly. You can also keep the conversation going on the chat on the platform, chat area there. And don't forget to attend the next live session at 1 p.m. So grab some lunch and then go back to the platform and attend your next session at 1 p.m. because you want to get entered in for those drawings. So we will see you again at 1 p.m. Thanks, Ben, for your information today, and we will see you all again at 1 p.m.
Thank you, Crystal.